In this video, dissection of the hand will be demonstrated. This work was produced by Dr. Carlos Andres Suarez-Quian and Dr. Joel Walensky. Dr. Suarez-Quian is the narrator of this video. Our hands literally brought us onto this earth and what allows us to survive and thrive on it. We can use our hands to speak, to feed ourselves, to perform chores, and perhaps most importantly, to show our emotions for someone by giving them a gentle caress. Imagine what deficits are present in the individual who has lost the use of their hands. Knowing hand anatomy and function is vital for students seeking a career in the healing arts. Let's dissect the hand. The skin, muscles, nerves, and vessels of the hand all facilitate amazingly delicate movements, while also facilitating great grip strength when it is needed. The skin of the palm of the hand is thick and hairless. It is bound down to the underlying deep fascia by numerous fibrous bands present in the superficial fascia. These numerous fibrous bands prevent the skin of the palm from rolling as we glide our fingers on the surface of a table to pick up a penny. In contrast, the skin of the dorsal side is loose. It is the reason that the swelling of inflammation resulting from infection beginning on the palm of the hand migrates to the dorsal side of the hand. The fibrous bands prevent the swelling on the palm side, forcing the inflammation to migrate dorsally, where edema is readily noted. Finally, the skin shows many flexure creases at the site of skin movement, which are not necessarily placed at the site of joints. The deep fascia of the palm is very thick and tough. This thick fascia is triangular in shape and occupies the central area of the palm and is given the name of palmar aponeurosis. As it spreads to the thumb and little finger, the fascia thins out. The function of the palmar aponeurosis is to protect the underlying structures. Because of the tough superficial fascia and this thick, deep fascia, removal of the skin, superficial and deep fascia of the hand is very time-consuming. Deep to the palmar aponeurosis sits the flexor retinaculum, which is also part of the deep fascia. An abnormal thickening and tightening of the normally elastic palmar aponeurosis tissue is called the Poitras contracture. It manifests clinically in continually flexed fingers and associated hand deformities, more frequent in males and occurs as people age. Clearly, this condition significantly impacts individuals who depend on their hands for their livelihoods. For example, imagine a musician trying to play their instrument. Removal of the palmar aponeurosis, as stated previously, is tedious and generally takes hours to preserve the blood and nerve supply to the hand. One strategy to accomplish the removal is to tug on the tendon of the palmaris longus, if present, that in turn tightens the flexor retinaculum and facilitates the scraping away of the palmar aponeurosis without damaging the underlying structures of the hand. The flexor retinaculum, which is known clinically as the transverse carpal ligament, forms the tight ventral border of the carpal tunnel. In patients with carpal tunnel syndrome who do not respond to conservative treatments, this ligament is cut to relieve the pressure on the tunnel. Surprisingly, this does not seem to have any major adverse effects in terms of finger movements. Similar to the flexor retinaculum at the wrist, there are fiber sheaths along each of the digits that act to keep the tendons aligned with the metacarpals and phalanges. Sometimes swelling of the confined tendon produces a condition called stenosing tenosynovitis, which is more commonly known as trigger finger, in which the tendons no longer move smoothly within these fibrous sheaths. This can be very painful to the patient. Again, here, The surgical solution involves cutting parts of the sheath to permit more space for the tendons to move. After removal of the palmar aponeurosis, the superficial palmar arch of the hand is exposed. We wish to emphasize how superficial this arch is, and likely the source of bleeding from the palm of the hand from relatively minor cuts. The arch represents the continuation of the ulnar artery that did not pass through the carpal tunnel and joins a branch from the radial artery. In this specimen, the contribution from the radial artery is particularly robust. Metacarpal and digital arteries arise from this arch. When you look at your hand, you can see soft prominences on both the radial and ulnar sides of the hand. These are known as the thenar and hypothenar eminences, and they result from the underlying muscles for the thumb and little finger or pinky. The two superficial muscles of the thenar eminence are the abductor pollicis brevis and the flexor pollicis brevis. The names of these muscles specify what they do. The abductor abducts the thumb, whereas the flexor flexes it. Deep to the abductor is the opponent's pollicis. This muscle causes rotation of the thenar metacarpal. This allows for opposition, which is when the ventral surface of the thumb is brought in contact with the ventral surface of the fingers. Although we're not the only primate capable of producing thumb opposition, we are certainly the ones that evolved to maximize this action, which facilitated the use of tool making by our ancestors. The little finger has a similar set of muscles that have the same names, except the term minimi replaces pollicis. However, these hypothenar muscles are much smaller than those for the thumb and often hard to differentiate. There are two sets of intrinsic hand muscles that move the fingers, the lumbricals and the interossei. With further cleaning of the palmar aponeurosis, we can now see the lumbrical for the fourth digit. The lumbricals take their origin from the tendon to the flexor digitorum profundus. The lumbricals act to flex the metacarpal phalangeal joints and to extend the interphalangeal joints. They are known as the bye-bye muscles, the ones royalty used to wave to their subjects from a balcony or from an open convertible while on parade. As one might expect, the fingers are extremely well supplied with sensory nerves and blood vessels. These run alongside the digits as shown here. This image also shows how the flexor digitorum superficialis tendon bifurcates to allow passage of the profundus tendon, which inserts on the terminal phalanx, whereas superficialis tendon inserts on the side of the middle phalanx. The extension of the tendon of the flexor digitorum profundus to the distal phalanx and intervening in between the tendon of the flexor digitorum superficialis that ends at the middle phalanx is shown at better resolution in this slide. Unlike the other digits, however, the thumb only has one extrinsic flexor, the flexor pollicis longus tendon, whose muscle belly originates from the forearm. The flexor pollicis longus tendon inserts into the terminal phalanx of the thumb. The second set of intrinsic finger muscles are the interossei muscles. They are both dorsal and ventral subsets, with some of the ventral muscles shown here. The interossei provide for adduction and abduction of the fingers and also assist the lumbricals in flexing the metacarpal phalangeal joints and extending the interphalangeal joints of the fingers. All interossei are innervated by the deep branch of the ulnar nerve, shown here. The deep palmar arch is located deep to the extrinsic digital flexor muscles and is a terminal part of the radial artery. It is accompanied by the deep branch of the ulnar nerve. Similar to the superficial arch, metacarpal and digital arteries arise from this arch. This now concludes this presentation on the dissection of the hand.